This presentation was recorded at the 2015 ANZICS ACCCN Annual Scientific Meeting.
It gives me great pleasure now to welcome Professor Martha Curley. Dr. Martha Curley is the Alan and Robert Capoto Professor in Nursing Science at the University of Pennsylvania School of Nursing in Philadelphia. She holds a joint appointment in anaesthesia and critical care medicine at the university's Perelman School of Medicine and is a nurse scientist at Boston Children's Hospital. Her funded research has specifically focused on nurse-implemented interventions. Over several decades, her studies have illuminated relationship-based care when partnering with parents of critically ill children, supported parent present during invasive procedures and resuscitation, and have informed the practice of caring for critically ill paediatric patients with acute respiratory failure. Dr. Curley has also led the development and dissemination of core metrics in the field of paediatrics. Today she's going to talk to us about the toxic or healing environment in intensive care.
Thank you. Well, isn't this a beautiful country, right? I've never been here before. And so I'm really excited to have received the invitation. And so all the nurses at Starship who I met in Istanbul, where are you all? Okay, hi. So thank you so much for the invitation to come here. They met my husband on the boat, and they more or less made friends with him. And then we continued to take pictures throughout. And thanks, Nick, for the invitation. And thank you for listening to your staff and inviting me. And I've never been here, and so I am adding 2 whole weeks onto my trip here. So I am going to tour this beautiful country. I've learned a long time ago, thus the gray hair, that you don't ever go someplace and do a talk and go home, especially when it's 20 hours away on a plane. You kind of like hang out for a little bit. So when I was putting this talk together, or when I received the invitation, it always gives you entree to talk about something very different, or something that has been plaguing you for quite some time. And so I started off by thinking about intensive care environments, and thinking about where we've been with intensive care environments, and really thinking about whether or not the intensive care units that we've created are really toxic environments, or are they healing environments? So with that in mind, that's what I'm going to talk about in the next half an hour. And I bring greetings from the University of Pennsylvania School of Nursing and also Children's Hospital in Boston. I worked at Children's in Boston for over 20 years as a clinical nurse specialist, and then post-PhD as a nurse scientist there, and then moved to the University of Pennsylvania so that I could grow the discipline of nursing within a good school of nursing and grow doctoral students there. Some of you may not be aware that Harvard does not have a school of nursing. So my Harvard appointment was given to me to teach residents and fellows clinical research, and I really wanted to be able to do that to nursing, thus the move to the University of Pennsylvania. But I also go back at least once a month for a couple days on site, where I help staff nurses ask and answer clinical questions. And so my research as a clinical trialist is really embedded within the work of nursing, and it's resonated around how nurses take the lead in owning different pieces of their practice to make a significant impact. And I agree with Dr. Wolf that we all make our unique contributions to patient care, and I've been focusing on what is it that nurses do uniquely. So this morning I want us to probe the question, are ICUs toxic or healing? And then talk about several nurse-led therapies that I think can help us create, or at least support, a healing environment within intensive care. And I want us to take time to think about and to really envision the potential that we have in creating ICUs that are really healing milieus. And so, you know, milieus are environments in which we care. And if you just think back to yesterday or last week where you were, would you consider your ICU a healing milieu, or would you consider it somewhat of a toxic milieu? And, part of this is that we're all under pressure, but I also think that we have an opportunity under pressure to perform and to do things very differently. One of the pioneers of nursing who really spent a lot of her time thinking about the work of nursing is Dr. Patricia Bennett from the University of San Francisco. And she, with Pat Karakidis and Daphne Standard, probed through qualitative research methodology the work of nursing and discussed with a whole bunch of nurses what they did every day that made a difference. And they categorized what nurses do within 9 domains. And they're all listed here on the slide. But it's about managing crisis. It's about creating comfort for patients and families, caring for families. It's about using our clinical judgment to rescue patients from potential adverse events. It's about taking the lead, the moral and the ethical lead of nursing. But typically what I want to talk about today is how nurses really prevent hazards within a technological environment. Going back to Florence Nightingale, she said what nursing has to do is put the patient in the best condition for nature to act upon him. So what we do is to create care environments that sustain and support the patient's and the family's capacity to heal. And she said that a long time ago. She said it at a time where professional nursing had more to do with being whores and prostitutes than it had to do with taking care of sick patients. Some people say we probably haven't moved too far over, but it's different now. But what we do when we think about caring environments or strengthening the patient's capacity to heal, we really just work in places such like this, where it's sheer chaos, where the noise of the buffing machine is enough to drive anybody wild, where there's no day-night cycling whatsoever. And this paper was written and it said patients need to sleep for emotional health, for wound healing, to maintain a strong immune system. Yet the drama of the fractured and broken sleep pattern plays out night and day in most hospitals today. We really bring these people in who are pretty much sick, on the edge of their physiological well-being, and then we put them into chaotic environments, and we not really are unburdening them, but adding more burden to the situation. So if nursing was about creating an environment where we strengthen a patient's capacity to heal, we're really not doing that. The focus now is on delirium. You can't pick up a journal now without looking at delirium. So really the spotlight is on delirium. But if you think about it, the care we provide, it's amazing that any patient gets out of our intensive care unit without being in delirium. The atmosphere in and by itself, the no sleep-wake cycles, paying too much, the sedation that we put them in, really, if not anything, creates a patient who's in a delirium state, not necessarily manage patients through delirium. The things that I boxed out on these slides have to do with everything that nurses within their license, within their education, and within their expertise can manage independently. So really, going back to Florence, it had to do with the very first requirement in a hospital is that the sick, that it should do no harm, okay? And that's what she said. We shouldn't put people into hospitals and have the hospitals themselves be toxic. And I don't think we've moved too far from, Florence Nightingale Day. And from a more contemporary perspective, this is not my tattoo, in case you were wondering. If anybody has one like this, you can show it later. But, it is true today that that's what we should all be doing, no harm to our patients, and creating a milieu which strengthens somebody's capacity to heal. This enraged me when I first read it. It was an editorial in the New England Journal that talked about this new phenomena of post-intensive care syndrome. It says, during hospitalization, patients are commonly deprived of sleep, experience disruption in normal circadian rhythms, are nourished poorly, have pain and discomfort, confront a baffling array of mentally challenging situations, receive medications that can alter cognition and physical dysfunction, and become deconditioned by bed rest and inactivity. To me, when I read this, it was, wow. Seldom do we ever look beyond the intensive care unit. We kind of like focus what we're doing within the intensive care unit. But with the advent of post-ICU syndrome, I think if you look at what we're doing, all these things can be managed differently, easily, if we just pay attention to them. In adults, post-intensive care syndrome is known to cause functional deficits, cognitive impairments, and psychosocial and psychological problems at very high numbers in the adult population. So even though you survive critical illness, you may, upon discharge, be completely scrambled for months, so there you're not even yourself after you leave the intensive care unit. And you have to end up in months of rehab just to establish yourself or try to get back to normal function. So I believe the priority of where we are in this day and age is to focus on nurse-led therapies to manage fundamental aspects of care. And we have some really good examples where we have taken the lead. Definitely around, feeding patients a lot better and weaning patients from mechanical support. But I believe we have much more to do to deal with this. So as faculty at Penn, we have a inquiry-based residency that our senior students are expected to do. So I got 4 of them, to review the literature on noise and day-night cycled interventions in the intensive care unit, circadian rhythms, sleep, and early mobilization. And their names are here. And last semester, they went through and did systematic reviews. And I just want to review with you some of the highlights that they found out. It comes to no surprise that they're pretty noisy environments, ICUs. We are well above the standard of all recommendations in any population of intensive care patient, simply by putting a noise meter into a room without a patient filled with ICU equipment. The noise ranges are far above what's currently recommended. So we need to do something about the equipment, but also when we put the patient in the room, what do we do from there? So the equipment is an issue, but 24/7, the noise, there's fluctuations of that, so we have to do 24/7 monitoring. And really, staff education programs have done a significant improvement in the level of noise. So it can be something that can be modulated to bring down so that the patient can have a better environment. Going forward, looking at light, there isn't really good data around optimal light, but we know that cyclical lighting is better. For us who flew across country, there is a cycled pattern in planes coming here. And it's brought up slowly and it's brought down slowly, and it can really just change the whole environment of how one perceives their environment simply by the level of light and the type of light that is provided. And just saying that you have your patients with natural light doesn't really mean anything, because most of the time it's not really cycled. The light in the room is still not cycled. So the natural lighting is good, but you have to do something with that light. Circadian rhythms, forget circadian rhythms. Patients come in, we change their rhythm immediately upon entering the intensive care unit. They sleep during the day. Their feeding, if they're on continuous feeding, that ruins circadian rhythms. They should be bolused through the day. So there's some cycle there, but we put people on continuous feedings. Obviously, they're physiologically, stressed and they're critically ill, but melatonin levels are, way off the mark. And if you think about it, it's a vicious cycle. Patients have an altered circadian rhythm because they have an altered sleep pattern. They get agitated, restless, and irritable. Those of you who don't sleep on a normal circadian rhythm become that way. In the ICU, we give you drugs, which then alter more circadian rhythms. So before you know it, you have a patient who has essentially no circadian rhythm left, so they have no capacity to launch any defense forward. Sleep, again, sleep is not existent in the intensive care unit for both patient-related factors and sleep-related or patient system-related factors, and the pattern itself becomes disturbed. There's increased latency to sleep onset and more awakenings, and decreased total time of sleep, sleep efficiency, and REM sleep. So all this leads to very bad sleep pattern that's not a restorative pattern. We're getting depressed, isn't it? Really good. It's really depressing. But we are paying attention to some good stuff, like getting patients out of bed and getting them moving. Hot topic is moving patients on ECMO. And in pediatrics, we have 3 big sets of researchers who are doing some really cool stuff, getting even the smallest of kids up into a routine. And we definitely have broken through the oversedation barrier so that our patients can participate in some of this. So where we are now is nowhere. We have lots to do, but there's lots of potential to move forward. And so I think what we can do is just really change the paradigm of critical illness. And this is the lobby of Chicago Children's. And you just walk into this atrium and it tones everything down dramatically simply by looking at the environment a little bit differently. And so what I want to tease you a little bit with is an intervention that I'm calling Restore Resilience. And the resilience piece of this is critically important because every single patient has some capacity for restorative function. And again, what nurses do is kind of strengthen every single patient's fundamental need for or capacity to become resilient. And so it's about creating healing milieus, but it's also about the patients themselves and moving forward to hopefully better able them to do it. And this says, bummer of a birthmark hell. What this means is that we so totally change environments for everyone. We decide that day-night cycling is good, that we want to take some nap time. And so from like 12 to 2, we tone down the lights. But if 12 to 2 is typically when somebody is really active, it really doesn't do it for the entire population. So the things that we have been doing, we just need to target more specifically at an individual in how they normally behave when they're not so critically ill. So the things I want to talk about are just 6. The day-night cycling and noise containment. I want to talk about circadian rhythm interventions to match the patient's routine, minimum but effective sedation, progressive early and progressive mobility, the potential of ICU Diaries and what they do for patients after critical illness. And then I want us to think about continuity of care. I want us to think about how we have within our staffing schedules the capacity to put people who know each other better at the bedside so that we could provide a safer environment for patients within our control. And it goes continuity of nursing care, but also continuity in medical care as well. So let's just talk about day-night cycling. I don't know what the hell my cycle is right now. I'm trying to figure that out. I'm a little off, but I think I'm 4 hours ahead minus 1 day or something. That's how you do it. But simply by changing the lighting pattern in a unit automatically on a timer could change the whole milieu. Typically, night nurses come in and they turn off all the lights, and that's how they start their shifts. But it may be if you put it on a timer, they wouldn't have to do that, and it would just come down gently and then come up according to the cycle of the season. So it's an easy intervention to be made, and when it's done, a few places have done it from an architectural perspective, the whole milieu immediately changes. Noise level to match the routine and the development level of a patient is really important. What you do for an adolescent is something very different than you do for a geriatric patient, very different than you do for a newborn. So you have to match it to a developmental level and give them the noise you think might be their aura. They may need that, but give them what they need. The devices that you see here, these noise, these ears or these red level, usually when you put them in units, and the louder it goes to red, and the better the noise goes to green. Usually people try to talk louder to make the colors change. So they really haven't been proved to be effective, but definitely at least being mindful of the noise at least would help you go in the right direction. Noise limitation is also good for work environment themselves. How many of you do music therapy within your intensive care unit, where you have a harpist or somebody who comes in routinely? As soon as that starts, the whole milieu of the unit changes. People start talking softer and moving around the unit softer. So anything we can do to modulate that is good for us as well. When we implemented nap time in the unit, the nurses loved it because you weren't allowed to touch your patients if you came in from 12 to 2. Everything got quiet, and everyone got caught up on work that they had to do. All the documentation got caught up on, and it became, coming out of the end of the nap time, nurses were more themselves resilient to continue with another 6 hour of shift. Circadian rhythms is something, number 2, I think it would be easy to do in the intensive care unit. And these are my grandchildren. And I became really aware of what happens with circadian rhythms watching them. If you screw with a toddler's rhythm of the day, you're screwed. You can't do it. You have to do what you do to keep them happy. If they miss their snack time, if they miss their nap time, if they miss their bedtime, you're screwed. I mean, it takes you a day to recover. So as soon as I figured that out, I was like, what do we do with these poor kids when they come into the hospital? And can we do it differently? So we're starting to give families sleep questionnaires. This is Sabna Kudachar from Hopkins survey, just to tell us about your child and how they normally go to bed. I mean, all of us have our rituals of how we go to bed and how we sleep and how we position ourselves, the whole thing. So why can't we do that within the intensive care unit? But pushing it forward, we added on a question about what is it that what do you have for your child's routine? And this is my Claire Bear's routine. My daughter-in-law filled this out. It only took her 10 minutes. And this is what Claire does. When she gets up, she has breakfast, she watches a little bit of TV, she usually goes out and plays, she has her lunch, she nurses, etc. So asking families to do this when their kids get admitted to the hospital and then matching this to the work of the unit is low-hanging fruit. It would not cost a lot or do a lot to maintain this, because if we're going to get them out of bed anyway, why don't we just do it when they normally are more active? Bring the child life therapist in when they usually have playtime at home. Instead of doing continuous feeding, do the bolus feeding, the cycled feeding, when they're regularly ready to eat. So this is what we're now studying at Children's Hospital Philadelphia. We're testing the feasibility of giving parents this opportunity to tell us about their children when they're admitted, and then the next step is, can we map that to the work of the unit to maintain circadian rhythm within intensive care unit? And at the very least, what we can do is take their routine and at least give it back to them before we send them home. So at least if we can't get it going, we can at least end with it so that their child, when they do go home, is somewhat like themselves at home. So I think not only does this as an easy intervention to do, it aligns well with family-centered care, how we want to bring families in and interact with them differently with decision-making and with care within intensive care unit, no matter the age of the patient. Number 3, I think the adult practitioners have significantly maintained gains in this more minimum but effective level of sedation. We just finished a study, the RESTORE clinical trial, that shows that you can have more awake pediatric patients who can be more interactive with you in intensive care, and you can do it safely. And a lot of this is just not in training the status quo. Forcing titration of sedative to match the patient's trajectory of illness, but also match when remove it when they no longer need it so that they can participate more actively in the work of healing that they have to do. Which is early mobilization protocols, obviously here done with a safety screen, and as patients get better, they have more and more activity so that you can prevent all the muscular deterioration that currently happens when patients are immobile. And this is the ABCDE protocol that's off the American Association of Critical Care Nurses website, progressive mobility, along with now involving the family at the end so that the families become more involved. So the protocol now is ABCDEF with family involvement and family stress to decrease that as an initiative as well. And Michelle Ballas's work has really started to give us data to show that when you prevent patient deconditioning by simply getting them up and moving, you do have better patient outcomes. You get them off the ventilator quicker, they leave the ICU in hospital quicker, they return to better normal brain function earlier, independent functional status, and obviously improved survival. So there's good data that shows you can't let patients just sit in ICUs without getting moved. And definitely the major facilitator of that is the nurse at the bedside that says, yes, we can do it. We can lighten the sedation, we can get the patient out of bed, and we can get the patient moving. And in pediatrics, we're just starting to study this. Sapna Kudachar's work, who works with Dale Needham at Hopkins, has developed a pediatric protocol to get pediatric patients up and moving, and she's currently testing that. And hopefully, by the end of the year, we'll have a nice publication describing the pilot work and the next steps that can be used for that. Number 5 is ICU Diaries. The amount of PTSD that patients have after critical illness is significant. Not having memory of the event is significant. So trying to embed intervention simply by asking families to complete an ICU diary decrease the incidence of PTSD. Low-hanging fruit. Give somebody an iPad, give them something to write down their thoughts, their feelings, so that they can remember it and then debrief it after critical illness is a huge intervention. And here's an example of an ICU diary in pediatrics, and this is Fiona Lynch. This is a nurse, I think she's at the Brompton, I'm not sure, Fiona was written in the diary where the parent took pictures, so she had memories of who was the person or who were the people that were taking care of her child when they're critically ill. So many times people come back to the ICU and they don't even remember you because of all the drugs they were on. At least if you give them some mechanism to remember the event, they could process the event and decrease PTSD. And finally, it's about relationships. We have the capacity to improve how we know individual patients and their families, but also improve the capacity that individual patients and families have of us. We can be a burden to families because if you don't know the caregiver at your loved one's bedside every single shift, it's very hard to leave the bedside, feel as though you trust that individual, and really partner with the individual. So by improving continuity of care, it gives us an opportunity to develop more therapeutic relationships with these individuals that are very stressed, hopefully moving them on to a different place. And so to compute continuity of care is quite simple. You could just start doing it by looking at the number of different nurses, different physicians, if you want to compute physician continuity, that the patient gets exposed to over a certain amount of time or during the entire hospitalization. And we've been doing this, and we relate it back to length of stay because some of this is a function of the amount of exposure somebody has an opportunity to experience, and then we do track it over time. Here we see that we really were quite flat in the continuity of care, but then once we started embedding length of stay, we were really hitting our goal of a 0.5 continuity of care index on patients with very long lengths of stay, which was really quite cool. Because again, decreasing the amount of people somebody even has to know unburdens you from having to explain all the time what's going on. So in thinking about these 6 different pieces, about light and noise, about circadian rhythm, about sleep, about appropriate sedation, and really about getting people up and moving, giving them some memory, I think we can improve the environment, and we can create what I refer to as healing milieus. And we can start measuring the impact of whether or not this level of care will improve patient outcomes by symptom management, time to physiological stability. If we know patients, we can get them to be more physiologically stable quicker. We can help patients and families feel better. We can improve short-term outcomes and then definitely the long-term outcomes and impact this post-intensive care syndrome, which I do believe in part is something that can be manipulated specifically by nurse-led independent treatments that are low-hanging fruit. Getting back to the fundamentals of nursing care, getting back to what Florence Nightingale said, put the patient in the best condition for nature to act. So the practice of critical care takes multiple disciplines. We share some core values. We share the primacy of patient and family. We share the spirit of inquiry. And we also share the innovation that we all have the capacity to contribute to. And so with that, I'll end and say, please, let's continue to challenge the givens. Thank you.